Assalamualaikum warahmatullahi wabarakatuh. Dear students, hope you are all fine by the grace of God. Bismillahirrahmanirrahim. So we'll continue with the previous topic, that is Anti-Partum Hemorrhage. Yesterday we discussed about one of the major causes of Anti-Partum Hemorrhage, that is the abruptio placenta. When the placenta is separated from the uterine wall, placenta that is normally implanted. So that is abruptio placenta. So today we will discuss the other placental cause of antepartum hemorrhage. So what is antepartum hemorrhage? You all must know. Antepartum hemorrhage is the bleeding from the genital tract after 24 weeks of pregnancy, that is the age of viability. After the age of viability of any bleeding during pregnancy and it is before delivery, it is called antepartum hemorrhage. Anti means before, partum is delivery, hemorrhage is bleeding. So this is antepartum hemorrhage. It affects about 3 to 5% of all pregnancies. So the main causes of antepartum hemorrhage, they are placental or local causes or unexplained. So the placental causes, we discussed about placenta yesterday. Today we will discuss placenta previa. And the other causes include, which are local causes, is local cervical infections or local infections. There are tumors or bleeding from the vasa previa. Now, what is placenta previa? When the placenta is implanted partially or wholly over the lower uterine segment, over and adjacent to the internal os, it is called placenta previa. Previa means in front of. So it denotes the position of the placenta in relation to the presenting part. So it is the incidence is about 0.5% of all the deliveries. As you can see over here, there are different types of placenta previa. Type 1. This is type 1, in which the placenta is encroaching the lower uterine segment. This is the upper uterine segment and this is the lower uterine segment. So when it is encroaching over the lower uterine segment, we call it low-lying placenta or type 1 placenta previa. And when it reaches the cervical os but not covers it, then it is called type 2 or marginal placenta previa. And when it covers the internal os, this is internal os, this is external os, this is the cervical canal. And when it covers the internal os, then it is called a type 3 placenta previa. And when it is centrally placed over the uterine segment, it is called complete or type 4 placenta previa. So type 1, type 2, this and this. Type 2 anterior. If the placenta is on the anterior uterine wall, they are considered as minor placenta previa. And type 2 posterior plus type 3 and type 4, they are called major degree placenta previa. So we divide placenta previa on the degree of it covering the lower uterine segment and the cervical os. Type 1, when it encroaches over the lower uterine segment, this is type 1. This is type 2, when it reaches the os but does not cover it. When it covers the os, is type 3, and when it is centrally placed is called complete or type 4 placenta previa. So we divide these 4 types into major and minor degree. The minor degree includes type 1 and type 2 anterior, while type 2 posterior and 3 and 4, they are major degree placenta previa. So this is how we divide according to the site of the placenta. Now, what are the factors which may contribute towards the lower-lying placenta or placenta previa? Multiparity, increased number of pregnancies. advanced maternal age. Previous cesarean section is a very important risk factor. If a patient has a scarred uterus, she had a previous cesarean section 1 or 2, is likely to have more and more chances of developing placenta previa than its pregnancy. So any kind of uterine surgery like myomectomy, DNC or endometrial ablation, they all can lead to development of low-lying placenta or placenta previa. Multiple pregnancy also leads to placenta previa as there is a larger placental site and some of the portion of the placenta may encroach the lower uterine segment. Smoking is another risk factor. It is also associated with IUGR and placental abruption in 10% of the cases. So, these are the risk factors in which we may encounter placenta previa. There are different theories regarding its etiology, that there is persistence of the chorionic activity, big surface area of the placenta like in multiple pregnancy, or there is defective residue at that place which does not allow placenta to move upward. So that's why there is placenta previa. Now, what happens? There is formation of the lower uterine segment in the third trimester. There is slight dilatation of the cervical os. It leads to tearing of the placental attachment, and which in turn cause inability of the myometrium in the lower segment to contract and it may lead to bleeding. So whenever there is dilatation of the cervical os, and it will lead to the detachment of the placenta at that area, which as we all know that the lower uterine segment has no ability to contract, so it will lead to bleeding from that placental site. How the patient will present? She will present obviously with bleeding per vaginum, but it is painless, sudden in an onset, and it is painless. She will say, that I was sleeping, I suddenly started bleeding. So sudden in onset, and it is painless. There is no pain. While in abruption, there was pain, and there is no obvious reason for the bleeding to occur. And she might have previous history of recurrent episodes of this painless vaginal bleeding. And when you will examine the patient, you will find that this tachycardia, increased pulse rate. She may be having low blood pressure, hypertension. She has excessive bleeding. There will be signs of anemia, and an abdominal palpation. You will find that the uterus is, according to the gestational age, there will may be a malpresentation, and the presenting part is high, and fetal heart sounds they are present. While on vulval inspection, you will not do digital examination, because if it is placenta previa diagnosed case, then if you do digital examination, it will provoke diffuse hemorrhage and patient may go into shock and she may die of the shock. So that's why she is not examined digitally. You can only do gentle post-vacuum examination to see any local cause of bleeding, to rule out that. So digital examination or vaginal examination is contraindicated in case of placenta previa. So patient comes to you with painless vaginal bleeding. How you will diagnose? On history, she will say it is painless. And when you will examine abdominally, clinically, or on general physical examination, she will have tachycardia, she may have hypotension. On abdominal examination, the abdomen is soft, non-tender, and the presenting part is high. There will be malpresentation, either transverse lie, oblique lie, or breach, and fetal condition is stable. So there will be no evidence of fetal distress until unless patient goes into irreversible shock. So this is clinical diagnosis, and for confirmation of the diagnosis, you will do ultrasonography. So transvaginal scan is most appropriate to localize the placenta. Transabdominal has 5% on transabdominal scan, 5% having low-lying placenta at 16 weeks to 18 weeks. They will grow, placenta will rise upwards, and only 0.5% will have placenta previa delivery. So the placenta rises in later gestational ages, and only 5.5% they will have placenta previa versus in placenta previa delivery. But on transabdominal scan, it is difficult to determine posterior edge of the placenta previa. That's why TVS is better. It does not need full bladder. There is less distortion of the uterine segment and cervix, and it does not provoke bleeding also. So the TVS is the best option to localize the placenta. MRI is expensive and it's not superior to TVS performed by the experienced person. The MRI is reserved only for those cases in which you have not confirmed your diagnosis on TVS. This is a scan showing placenta previa. This is uterine wall. This is cervix, internal os. This is cervical canal, and this is spongy structure is the placenta. So this is the placenta, which is covering the internal os. This is lower uterine segment. This is lower uterine segment, and this is the placenta, which is occupying the lower uterine segment and covering the os. So this is major degree placenta previa. Again, this is a vital canal. This is internal os, and this is the uterine wall, and this is the placenta, which is reaching the cervix. So this is another picture showing placenta previa. So this is placenta previa covering the cervical os. So this is type 3 or type 4 placenta previa. Again, this is urinary bladder. This is cervix, and this whole spongy structure is the placenta. And you can see over here, this is the Doppler ultrasound also. This placenta previa has blood vessels invading the uterine wall and some reaching the bladder also. So this is Doppler ultrasound showing placenta previa with its it is invading the uterine wall, myometrium, and some vessels reaching the bladder wall. So this is morbidly adherent placenta, which we will study later. So ultrasound with Doppler studies showing placenta previa covering the cervix and also invading the myometrium. This is the myometrium. These are the blood flow vessels showing blood flow into the myometrium, and these vessels, they are also reaching the bladder. This is the urinary bladder. This whole area filled with urine is urinary bladder. So some of the vessels, they are invading the urinary bladder also. Now, what complications can occur in case of placenta previa? During antepartum period, patient may have malpresentation. It will be a transverse lie or oblique lie or breach, and she may go into premature labor due to excessive bleeding. Intrapartum, if it has minor degree placenta previa, there may be early rupture of membranes, cord may prolapse. There will be a slow progress of labor, or excessive hemorrhage may occur during labor. In perpurium, The patient with placenta previa may have sepsis, delayed involution of the uterus if there are some retained pieces inside, or there is a risk of embolism in the postoperative period. Fetal complications due to repeated episodes of bleeding, the baby may be without weight or IUGR. There may be congenital malformations or with excessive bleeding. Baby may have fetal distress, asphyxia, birth asphyxia, or intrauterine fetal death in case of irreversible shock in the mother. Or the baby may receive birth injuries during difficulty in delivering the baby. The placenta previa has a mnemonic regarding its care. Previa. P for painless bright red bleeding. R to replace the blood loss, blood for blood, and E evident in the lower segment. V vitals indicate shock. I inspect fetal heart rate, check for fetal heart rate, and A is avoid vaginal examination. So this mnemonic helps you in the management of the placenta previa. The management depends upon the gestational age, the amount of bleeding, and the condition of the mother and the baby. So these patients, they can be managed either expectantly or actively by doing emergency cesarean section or planning an elective cesarean section. The expectant line of management is also called McAfee-Johnson's regime. Its aim is to continue pregnancy for fetal lungs to mature without compromising maternal health. So the prerequisites are availability of the blood transfusion, if there is availability of the blood, and there are facilities for cesarean section. They should be available for 24 hours. If you are managing the patient conservatively, there should be blood at hand and the 24-hour emergency operation theatre facilities should be present. So in case of any emergency, you can do emergency cesarean section. So this is McAfee-Johnson's regime. So expected management is done in those cases in which baby is preterm, there is mild bleeding, and the patient is not in labor. So we will hospitalize the patient, advise her bed rest, and keep her under observation. We will arrange and cross-match at least 4 units of blood. Correction of anemia, if she is anemic, we will transfuse blood, and we will do maternal fetal monitoring. If she is Rh negative, we will give her injection anti-T, and we will plan her elective section at 37 completed weeks of gestation. So this is the expectant management or McAfee's regime. If the patient is in labor, we can give a trial of vaginal delivery in case of minor degree placenta previa. What was minor degree? It was type 1 and type 2 anterior. If she goes into labor, we will allow her to deliver vaginally if it is minor degree. Or there is mild bleeding, baby has vertex presentation, then this is adequate for that baby, and there is the cervix starts dilating and it allows amniotomy. So when we will do amniotomy, it will have two benefits. It will allow the liquor to drain, head to fix, and it will compress the placenta, preventing further bleeding. And it also abolishes the shearing movement of placenta during uterine contractions. So this is done in case of minor degree placenta previa when there is type 1 or type 2 anterior placenta previa. Then we can give a trial of vaginal delivery. But if during this trial, if it starts bleeding profusely, then we will go for emergency cesarean section. Now, cesarean section is indicated in case major degree placenta previa, even if the baby is not alive, if the patient is having severe bleeding and she is going into shock, or if there is a placenta previa minor degree with non-vertex presentation, or any other obstetric indication like CBD, cord collapse, or vasa previa. So these are the indications for cesarean section in case of placenta previa. Now, this is the algorithm showing the placenta previa management. If the patient is having severe bleeding, we will start resuscitating and prepare for cesarean section. If there is moderate bleeding, then we will see if it is less than 34 weeks. We will resuscitate, give steroids, and make her stable. If she is stable, then we will manage as conservatively, but if it becomes unstable, we will go for cesarean section. And if she is more than 34 weeks and she is having moderate bleeding, then we will do emergency cesarean section. Now, if the patient has a mild bleeding and she is stable and gestation is less than 36 weeks, she is preterm, then we will manage conservatively. But if she is more than 36 weeks, then we will go for emergency cesarean section. So this is the management plan, depending upon the degree of bleeding and the gestational age. This is the comparison between placenta previa and abruptio placenta. Painless vaginal bleeding. In case of placenta previa, it is bright red in color. First episode of bleeding is light, then becomes profuse. Signs of blood loss comparable to the extent of the bleeding. Uterus is soft, non-tender. Fetal parts are palpable. Fetal heart sounds are present, and clotting profile is normal. While in case of abruption, bleeding is accompanied by abruption and pain. Dark red bleeding. First episode of bleeding usually profuse. Signs of blood loss out of proportion to visible amount of bleeding. Uterus is board-like or woody, hard, painful. Fetal parts are not palpable. Fetal heart sounds are not audible, and the clotting profile is disturbed. So this was all about placenta previa. Now we'll discuss the morbidly adherent placenta. What is morbidly adherent placenta? Normally, the placenta attaches to the uterus and until labor when it separates with the help of the contractions. In case of placenta accreta, the placental chorionic villi adheres to the superficial layer of the uterine myometrium. So the placenta is adherent to the uterine myometrium. This is placenta accreta. And what happens in placenta increta? The placental chorionic villi invade into the myometrium. In creta, they will invade the myometrium. As you can see over here, this is the placenta. This is placenta. This is the myometrium. This pink, light pink is myometrium. So this is normal placenta, which is lying over here in the upper segment. This is placenta accreta. It is adherent to the myometrium. This is accreta. Here it invades the myometrium. It is increta. That is, it is going into the myometrium. So that's why it is called increta. And this is percreta. It goes into myometrium and comes out of the perimetrium. So this is percreta. So these three types are morbidly adherent to placenta previa. Accreta, increta, and percreta. This is accreta adherent to the myometrium. It invades into the myometrium, increta, and percreta goes out of the myometrium into the perimetrium. So this is how we describe the placenta, morbidly adherent placenta. Again, this picture shows that this is normal placenta. This pink color, light pink, is myometrium. This is accreta adherent to the myometrium. This is increta invading into the myometrium and is going out of the myometrium into the perimetrium. So this is percreta. This is the effect of the descent of the xylus in conjunction with an imperfect development of the Niederberg membrane. So it results in the abnormally invasive implantation of the placenta. Niederberg membrane is a fibrinoid layer that separates the testicle xylus from the placental villi. So whenever there is imperfect development of this stitchable membrane. It will lead to development of morbidly adherent placenta. So how we will diagnose? With the help of ultrasound, Doppler ultrasound and MRI and alpha fetoproteins and HCG. On ultrasound we will see this is bladder, this is uterine wall, this is cervix and this is the placenta previa. So this placenta previa is adherent to the myometrium, so it is placenta accreta. In the first trimester, how you will diagnose on ultrasound, signs of secretion may be seen as early as in the first trimester. Low-lying gestational sacs which are clearly attached to the uterine scar. So in case of first trimester, when you will do ultrasound, you will see gestational sac is low-lying and it is attached to the uterine scar. The myometrium has thin in the area of scar to which the sac was attached as compared to the normal early gestational sacs. So this is the first trimester ultrasound you can detect on these 2 points. When you go, the patient enters the second and third trimester. So when we will do scan in the second trimester, there will be loss of continuity of the uterine wall. There will be no continuity in the uterine wall. There will be multiple vascular lacunae, irregular vascular spaces within the placenta, giving Swiss cheese appearance adjacent to the placental implantation site. And the second point is lack of a hypoechoic border. The myometrial zone, the hypoechoic border, is lost between the placenta and the myometrium. Bulging of the placenta or myometrial site into the bladder. Sometimes there is bulge of the placental tissue into the bladder. This is the color Doppler demonstrating. You cannot see the color over here. The turbulent flow is seen through the placental lacunae. These are the placental lacunae with abnormal vessels linking the placenta to the bladder. So this is placenta, this is bladder, and these are the abnormal Doppler flow into the myometrium and even into the bladder wall. So this is morbidly adherent placenta. Again, this is fetal head, this is body, placenta. So this placenta is adherent to the uterine wall. It is adherent to the myometrium. So this is placenta accreta. You can see multiple vascular lacunae. Again, inside the placenta. This is whole placenta with loads of lacunae. So this is placenta previa. After doing ultrasound, if you cannot diagnose on ultrasound, then you can take the help of MRI. The role is to complement rather than replace the information obtained by the ultrasonography. Yeah, the advantage over other investigation modalities is that it has ability to diagnose posterior placenta accreta more confidently, and assessment of the bladder invasion can also be done on this basis. Now, the role of AFE and HCG. Elevated levels of alpha-fetoprotein and human chronic tryptophan within the triple screening test has been reported to be associated with an increased risk of placenta accreta. When you do triple screening in the first trimester and you have raised levels of AFP and HCG, then you can predict that this patient might have placenta accreta. Though the mechanism is unclear, abnormality of the placental uterine interface that may lead to leakage into the maternal circulation, it may be the possibility that um, explain this increase in AFP and HCG. So that's why these two hormones they are increased in cases of placenta previa. So what are the complications which we may encounter in such cases? Obviously, such type of placenta is not easy to remove. It is adherent and it will lead to massive hemorrhage. Due to massive hemorrhage, you have to transfuse massively, and these massive transfusions may lead to IC. She may go into acute respiratory syndrome and renal failure due to hemorrhage and excessive blood loss. Due to long surgery, she may have infection, and sometimes there is death of the patient due to these complications. What should be the management plan? If you have a diagnosis of placenta previa, incorrect or work elective cesarean hysterectomy, right? Multidisciplinary team. It should be our management plan. Elective cesarean hysterectomy with multidisciplinary team. So there is a great benefit of planned as opposed to emergent peripartum hysterectomy. So you always plan a surgery for such cases rather than to do an emergency hysterectomy. In mothers with placenta previa and the suspected atheta who required peripartum hysterectomy, delivery has been associated with shorter operative times. We have already a planned surgery. We will have shorter operative times. There will be less complications, less frequency of transfusions, and decrease ICU admissions. So always plan an elective cesarean hysterectomy with multidisciplinary team. You stand by everybody along with you so that you should have a surgeon, you should have a vascular surgeon, you should have a hematologist available, and physicians to do in the postoperative period. This is placenta incarnata. The placenta is encroaching the myometrium. This is again, this is uterus. The hair should be, this is the broad ligament, and this is the placenta, which you can see big vessels coming out of the myometrium. So this is placenta, and this is the uterus. This is the operative field. So it is adherent. Now what is multidisciplinary? You should know it should include gynecological surgeon experienced in pelvic surgery, blood bank team, prepared to administer multiple blood components, experienced anesthesiology personnel who are skilled in obstetric anesthesia, urologists in case of bladder resection or repair, experienced intensivist for postpartum care in ICU, experienced neonatologist, and in case where pelvic artery catheterizations are used, experienced interventionist. This is a multidisciplinary team. Preoperative management includes the women should be informed of the diagnosis and potential complications. Antenatal steroids should be given, consent for cesarean hysterectomy and skeletal. A preoperative anesthesia consultation should be obtained. Adequate blood and clotting practice should be available at the time of delivery, and in ICU should be available for postoperative care as needed. So, in placenta previa, the baby is always okay. Only it's the mother who is at stake. Intraoperative management. While you have opened the uterus, how you will plan the cesarean hysterectomy. A vertical skin incision provides good exposure. A vertical uterine incision is made above the upper edge of the placenta So you localize the upper edge of the placenta with the help of the vessels which are seen on the uh, uterine wall, and you will give incision above the upper edge of the placenta. Deliver the baby and left the placenta in situ with minimal manipulation. Peripartum hysterectomy is then performed. Peripartum hysterectomy is then as planned should be done. Hysterectomy immediately after delivery of the baby without attempts at placental removal had been reported to lower the mortality and morbidity rates compared to conservative management, especially in cases of placenta percarita. So, what you will do? You have delivered the baby. Do not try to remove the placenta. You just start doing hysterectomy, static hysterectomy, so as to minimize the blood loss in case of placenta percarita. Bladder care. In cases of percarita, the placenta is usually involving the bladder wall also. So placenta accreta is most likely to affect the urinary bladder. Accreta that invades the urinary bladder, that is percarita, not accreta, invade the bladder wall, may cause urinary fistulas and bladder lacerations requiring partial or total cystectomy. So data suggests that preoperative uteric stent placement may help reduce the risk of uteric injury. So you will involve the urologist and you may pass the uteric stents first to avoid the injury to the ureters. The bladder involvement, if suspected, then cystostomy may be needed after devascularization of the uterus is achieved and to ensure so this is how you will take the bladder care in cases of such morbidly health placenta. Thank you very much. So placenta previa, we have already given tests also regarding. If you have any query or if you have any questions, you can ask.